directors tell me otherwise, that this has been discussed at the local GP networks, at the clinical forum, where all the GPs come together.
Which GPs supported it, Brent? Can you tell us it?
All the GPs have signed up to the constitution of the CCG.
Yeah, that's a constitution.
Yeah.
This proposal to destroy our health services in the whole. Which of our GPs, apart from you, support it?
Some of us are waiting, but some people are...
Yes, exactly. Thank you very much.
I don't want to answer the question.
Thank you.
You have no support from GPs.
I've got several people waiting who haven't asked a question yet, so please.
So can I just
get the doctors to answer the questions that are being asked.
She's trying to answer.
It's a simple question. Which Brent GPs support you, Dr. Cole?
Okay. We have 5 localities. I repeat, we have 5 localities with 5 clinical forum meetings every month, where all GP practices are welcome to. Nurses, doctors, and practice managers are welcome to those meetings. This strategy, shaping a healthier future, has been discussed at all the GP network forums. So you can go back and ask your GPs. If your GPs...
Well, 22 Brent GPs told me they do not support it.
Well,
they're the only ones that responded
you can
to it.
send those GPs' name to me.
No, I'm not going to put them up.
Okay, we're in the last 5 minutes. I'm going to move this one on. The lady in front was here earlier and has a question.
At the North West London Overview and Scrutiny Committee, a request was made for a survey to be conducted of the GPs. So we hope that that might be taken forward, because then that would be a way, if it was a confidential survey, then we can all see what support there is amongst the GPs. So I hope to take that on board. I want to support the lady who spoke, I think, first about all this talk of care. Because if you look at that first board with 8 sort of areas where care will be provided, I found it very confusing. Health centre, how does that differ from a GP practice? What is a care network? How does that relate to the local hospital? How does the specialist hospital relate to the local hospital and the elective hospital? We've got elective maybe part of specialist, and major can also be provided in a local hospital. This is all extremely confusing, and it looks like we're just restructuring to confuse and to break things down into bits, which some of us feel is headed towards privatising. Well, we'll flog off this bit, we'll flog off that bit. And that's what's happening with that urgent care centre at Central Middlesex, run by a private outfit. We also know that the government is pushing for certain things to go out to tender, that they want more privatisation. We need to hear from the people who are involved, the GPs, the commissioners. You're going to stand up to that, because we're not hearing that at all. Now, when I've spoken before or asked questions in other forums, I said how I'm a member of Queen's Park Residents Association, secretary, and the letter that's just been passed by Robin to you saying of our concerns about the way this consultation is being conducted. I mean, Queen's Park has got very well-educated, articulate people, and they were struggling to find information. So Graham's point about the patients going to GP practices not knowing what's going on, I think we can understand that. And the second point is about that services have to be in the community before we see hospital services being cut back. And in addition to Queen's Park, my background is social work. I've been in social services my working life, and I left Brent as the Deputy Director of Social Services. So I've had experience of working with health. I remember in the 80s the ending of Shenley Hospital, long stay mental health, setting people in a community in a variety of ways with a variety of different type of health and social care support. I also know that when money's tight, you get to see bits of services disappearing, and it just quite ain't there. So in your document where you talk about how things will be, like with stars, that's already beginning to happen. So it's not a will be, that is part of things. We have seen things that have come onto the agenda and slid off the agenda because of finances.
Is there a specific question you want to respond to? It's at 12 o'clock, I still want to bring someone in who hasn't spoken.
Why is it a consultation?
If it's a two-way thing,
I'm just trying to move it along so we can chat.
Why do you want to run away at 12 o'clock?
Well, just wait and get to 12 o'clock and I'll see if we can extend it. But let's just get to 12 and see what we can.
I've said before, I am very suspicious. £120 million for 8 authorities over 3 years to beef up the services in the community is just not enough. Now, I cannot believe that the savings that are made on cutting accident and emergency, maybe that will generate 120 million. I don't know. Maybe it generates less, maybe more. But I find it very odd, this disjuncture between the cutting of A&E and what's going to be all singing, all dancing, bells and whistles, motherhood and apple pie. Of course we can all support better services in the community. That isn't the issue. I think there's a suspicion as to what's really behind it.
So, first point there was around privatisation. So, I've said before, and I'll say again, I'm opposed to privatisation in the NHS. I'm an ardent believer in the NHS. The government rules mean that we do have to, because of the rules we set up again under the last government, continued under the government, when there are, each CCG has been asked to tender for 2 services under what we call by any qualified provider. And those are normally things that are going out to private companies. In Brent, I don't know what the 2 AQPs are. In Ealing, it was hearing aids, and terminations have been done by Mary Stokes, as they always have been. So we had to go to private companies to do those, and we've done that because we chose the 2 smallest things on the list we could do because we ardently believe it's the wrong policy. But we have to buy the rules, and those are the 2 we've chosen to do that. It isn't about whole units being sold off to the NHS. We are trying to redesign something that is sustainable and safe that never needs to go there. And that's what we're trying to do. Locally, we have a large hospital at North Park which has real financial challenges. Unless we make these changes, there's a real risk that it will have problems. We try to make changes that gives it enough activity, pays for the PFI, simply the sector by getting all the elective work, that stops that risk of privatisation.
Okay. The gentleman in the middle here, you wanted to...
Yeah, very briefly, I think it's not so much saying to the doctor, but I think it's for the audience to say we have to remind ourselves that the National Health Service is ours, it belongs to us. And what I really present is that when we have a consultation, which is whether you like it or not, now you dress it up, it's going to be about cuts. When really what we need to have is a consultation that actually solves problems. So you've got a problem about maintaining accident emergency because of the technical problems of, whatever. We would like a consultation with all of us about how we solve that particular problem. How in as a local community, we demand that we keep that up to because of all the arguments about equality and the general level of suffering. The consultation would be about how we can actually improve the service, and when you look around, what you actually see is how it's always being piled off. I was born in 1940, so I've lived through the whole life of the National Health Service, and it's always been the same story. We can't afford this, we can't afford that, and every time from what I remember my father and the rest of it, we've always fought back about it. When I go out now and I go to my wife, we're going to collect even more petitions about going on, because this is about the only thing in Britain which is worth bloody defending. And therefore, I think it's an appeal to everybody in this room that we have to come together to actually defend the health service in whatever way we can. Next Saturday, there is a demonstration to defend Charing Cross Hospital and Hammersmith Hospital, A&Es and their services. My cancer was treated at Charing Cross, so it's something I'm emotionally connected to. I want everybody in this room, all of us, to actually be there and actually to tell people. It would be lovely if our answers to our questions were also on that demonstration as well.
I mean, you may know that the Imperial Board this week agreed that they don't think that maintaining their A&E at Charing Cross is sustainable and good, and therefore they've agreed that they should go for option A. That's what the hospital board have agreed that they should do. So, I mean, again, I believe, and you believe, we're both trying to fight to save the NHS. I believe I'm doing it by making a sustainable, better quality service. you're trying to sustain it by having maintaining services locally. There is always going to be tension between those two. I think we're both trying to fight to save the NHS.
Or with his finger in the diet, to be honest.
Okay, we're going to extend it. Ethic is stated 1/4 past. It might extend a little bit longer, so we'll keep going a little bit longer. But before I come back to people who've already asked questions, is anyone who hasn't had a chance to ask a question yet who'd like to ask one?
Go back to a second ago.
Gentleman,
Robbie must go.
It seems to me these changes are inevitable. We can accept them reluctantly, but they're inevitable. What concerns me is how you will find out what the effect of the changes are on the health of the community. Who's going to monitor the effect of these changes to find out whether they're actually working or not? And what will you do about some of the burgeoning problems that you've got in the community, like increase in AIDS, low rates of vaccination, TB, and the health of the elderly? You talk very little about the out-of-hospital care that we've got. And I'd like to know how you're going to find out whether what you do is going to improve the health of Brent or make it worse.
Yes. Public health collects all the data. You rightly bring up a few things, like for example, immunization in Brent hasn't had a good uptake. What we've done is we recognize that, and then through the GP networks, we have collectively worked on it. So I'm pleased to say our immunization for our children is indeed getting better.
How do you know?
By statistics data we have collected.
We measure all these
Yeah,
things.
it's measured by public health. Do you want, I can send you the information.
Yes, please.
Yeah, if you think you're,
I do.
yeah. So definitely immunization is getting better. TB is addressed London-wide. Yeah, so we're addressing TB. And same with sexual health is a London-wide issue. So we are addressing those. Yes. Yeah.
So the NHS has got a lot better in collecting data along with the council. So now there's a huge amount of information. It is all available on the web, so people can go and look at it. The public health networks have a fantastic amount of information. What they've highlighted is huge variability from borough to borough, from GP practice to GP practice, in how good practices are at managing immunisations, how good we are at managing to treat asthma and so on. And that huge variation is one of the things that drives us. We must produce better, much more consistent care. And at the moment that needs addressing very urgently. But because we're measuring all those things, we're going to continue monitoring them, and any things where we see things deteriorating, we need to pay attention and understand why and improve that dramatically.
Can I ask a follow-on from that?
Let me just add first. Then
Yeah. I just want to answer Robin. Earlier you mentioned health inequalities in the area. Yeah. No, earlier on, I want to address that. As we know, quite a number of years ago, there are 10 years difference between a man born in Harlesden and a man born in Kenton. So from 10 years, we have reduced it to 8.5 years. So it's gone down 1.5 years difference. So we are getting there, but to change demographics, epidemiology in such a large scale takes time. But we have seen, I've seen within 25 years the drop has come down by not much, but 1.5 years. So hopefully we see it dropping. And how do we do that is your question, is prevention in primary care. So we are identifying at risk earlier, treating them earlier, and treating them in a joint up care in order to reduce complications. So we're addressing inequalities that way.
And the other thing to add to that is actually health inequalities. Drivers for it, only 20% only 20% of health inequalities is addressed by health service. It's education, it's housing, it's lifestyles, and all those things and local authorities, all of those things have a much bigger impact on health inequalities than health has. Health has an important part to play, and what's really exciting, there are lots of things about the health changes which I disagree with, but actually the development of health and wellbeing boards working much more closely with the council, with public health moving into the council, I think are all very important things that will help us address those needs more.
Very brief, because this gentleman's been waiting for ages.
Okay, it's just that what you've been telling us here about statistics is a snapshot of what's happening now. So what do you know about the sort of, the demographic changes? For example, it's clear, and I speak quite personally, that we're heading for an ageing population, an increase in that. And it's also, we know now there's going to also be a baby boom, and how does that affect us in the area? And how are these things changing also with you know, people who, with immigrant workers and so on, immigrants coming in and so on, and their health needs and so on. What do we know about that, and how's that going to relate? And what I find interesting is you talk about the improvements that are taking place, and yet somehow you now then want to change things that, you know, are going to actually make things worse. But there's no point in going on and just saying what the things are now if we don't know how things are going to change, and it relates to the whole issue of equality that we've been, the Eden Project and so on.
Is your point a similar one to that? Is the point you want to make similar to that, the question you've got?
Well, I'd like to make it my own way.
Let's answer that one first, then we'll come to you again, your own space. Okay, who'd like to assess modelling future population?
We've been working very closely with the public health teams and the health specialists in epidemiology to look at it. And that's one of the drivers behind the change, particularly the increasing ageing population. The very last thing you want to do with an ageing person when they become ill is take them into hospital unnecessarily. You need to have systems that maintain the health in the community, give them exercise classes, maintain their muscle strength, give them good diets, prevent diseases deteriorating to the point they need hospital.
Do we know how many we're talking about? That's what I'm asking.
We've certainly got the modelling that looks at all of those things, yes.
Okay, thank you.
The fundamental thrust of this shaping document is that there are 9 acute hospitals with A&E departments in North West London, and you want to run those down to 5, i.e. close 4 A&E departments in this area, and otherwise organise the hospital. And as a quid pro quo for that, you want to substantially improve services in the community, not just broad public health, diet and all that, but treatment of people in various ways. Nobody wants to spend time in the hospital if they can stay at home and get treatment there. So, of course, all that is welcome, and it's hugely overdue. I mean, people have been arguing for it for 50 years. So, but that means that one has doubts about whether it will really happen, because why hasn't it happened before? It doesn't particularly need a rundown of hospitals to achieve it. And in this document, you've got 4 pages on delivering care outside hospitals, and 76 on the reorganisation and rundown. It's a massive imbalance. And that again leaves one to doubt, is the community side of this really going to happen? So why haven't you consulted first on the out-of-hospital strategies, which only seem to be just emerging, and only if you're very resilient can you find online the Brent out-of-hospital strategy, part of the pre-consultation business case, the huge online document. They're now copies are here at this meeting, but I mean, it's the first time I've seen them in any public forum. So isn't it all out of kilter? In our conversation just before the meeting started, you more or less agreed that Dr. Spencer, this was satisfactory, but you're not responsible. Well, who is responsible? That's what we'd like to know. And we're putting the cart before the horse. That is are we not? That's my question.
So a range of different parts to that. So consultation, because of the rules around consultation, are around hospital services. And that's why the emphasis of this document is around hospital services. Yes. The government's rules about what you consult on. So we have to consult around changes in hospital services, and that's what we do. The bedrock behind all of that, and what enables that to happen, is the changes in primary and community services, which we don't have to consult on. And it's bizarre, I agree, but that's...
Are we mean because of legislation?
Yes.
Because it says if you want to clear the hospital, you've got...
But you haven't presented it.
So that's the background. Absolutely, we need to change primary community. We cannot change any hospitals until that's happened. So our thesis, and I think it's more a thesis because it's displayed and has worked in many places elsewhere, is that once you improve community services, your demand on hospital services reduces. And you can then start closing hospital walls and hospital beds. And there are very good examples of that around the country that have done that. It's only once they are in place and are working and are reducing the demand on hospitals that we can begin to change it. So we're saying, because we have the plans, we can financially invest in out-of-hospital services. In the past, we were stopped by investing in out-of-hospital services because the hospitals kept on overspending We had to bail them out with, this year we've lent all the local hospitals money, it was an overspent. Because we're putting together a financial plan that predicts change in hospitals, we're able to use money to invest up front into community service. That hasn't happened in the past because they haven't had the predicted savings.
So is that in this document?
It's somewhere it's in the pre-consultation document. Because
No, in this document, that you won't put this into place until you've
yes,
got these.
that's in that document.
It's in,
Yes,
can you
we
tell me why?
can look through it with you later. We are not going to change any accident emergency funds until we've made the investments in some premises to make them bigger. So if this consultation goes through as it happens, then we're investing in Northwood Park, we're investing in St Mary's to make them bigger and stronger, build more beds in them to take the extra workload. We're investing in the community so that when those things are all in place, then we begin to change accident emergency departments elsewhere. So we have, well, it's quite clear, we cannot make changes elsewhere until those things